Hello, everyone, and welcome to this ARC Talks webinar, where we'll be talking about GI involvement with amyloidosis and symptom management. My name is Lori Bulpett, and I'm the Manager of Healthcare and Education with the Amyloidosis Research Consortium, or ARC. And just a little bit about ARC, if you're not familiar with us. We were founded in 2015 with the mission to accelerate the development of and access to new and innovative treatments for systemic amyloidosis and improve quality of life for patients. We work closely with patients and patient organizations, pharmaceutical companies, researchers, physicians, and regulatory agencies to drive our mission forwards. Our four main areas of focus are improving the speed and accuracy of diagnosis, increasing the understanding of the science of the diseases, accelerating regulatory approval for effective treatments, and enhancing quality of life for patients. And I know symptom management is a concern. We hear a lot from patients. So it is such a pleasure to have Dr. John Clarke from Stanford here with us today. Dr. Clarke is a gastroenterologist and motility specialist and is an expert with amyloidosis and its involvement in the GI tract. Dr. Clarke will give a detailed presentation, and then we'll have him available to answer as many questions as time allows. I do see that some have already come in, which is great. The Q&A feature should be on the bottom left-hand corner of your screen, so feel free to type your questions in there as you think of them, and then we'll have time set aside at the end to answer those. And if you have any technical issues, feel free to type those questions in as well, and I'll do my best to answer those while Dr. Clarke is presenting. All right, so first we have just a quick poll that we'd like just so we can get an idea of who's with us today. And Dr. Clarke can know maybe he'll spend a little bit more time on one area if we have a lot of patients from a certain type. So we'll give about 30 seconds to answer, and then we'll get right into the presentation. Okay, so I think we should have gotten a good amount of answers. Okay, so Dr. Clarke, can you see the responses?
Yes, I can. Yes, I can. Thank you.
Yeah, absolutely. So mostly AL, and then we have some PCR as well, and then just a bit with localized. All right, and you can go ahead and get started whenever you're ready.
Okay, great. Thanks so much. So during the next 40 minutes, I'm going to talk about why amyloid will cause symptoms, what symptoms patients typically experience, what tests we currently have to offer and how they are helpful, what treatment options we have at present, what we know about hereditary variants, what new treatment options are on the forefront, and when to see someone in my field, a gastroenterologist. And a bit of background about me. I'm based at Stanford now, and I've been here since 2016. Prior to that, I was based on the East Coast, where I was born and trained, and then was at that point based at Johns Hopkins for about 17 years before moving west. And just start off, I'd like to talk a little bit about background and classification. And so when we think of amyloid, it's really a group of different conditions which are given one common term. And this refers to a systemic condition in which there's proteins that are typically located within the blood and plasma, where parts of those go outside of that tract and then deposit within the tissue that's outside of the cells. And we tend to lump this within one category as amyloid. because based upon pathology, it can look very similar. And this term was first coined by a German pathologist, Virchow, in 1854, who called it this based on the fact that when he looked at amyloid with a microscope, it looked very much like plant starch. But it's worth noting that when we use the term amyloid, we're often talking about a number of different conditions that look very similar with pathology, that may function very similar, but can be from different causes. And so there's a number of different subtypes with amyloid. In the older fashion, it would typically be called by two letters, where the first one is A for amyloid, and then the second is based upon the subtype that's there. And so AL is often reported to be most common, and this is where the type of amyloid that forms is based upon what's called light chains, which are protein fragments which are made from plasma cells. And this is often associated with plasma cell dyscrasia and some types of cancers. And this is thought to be the most common subtype at present. AA is typically where there's amyloid, but it's from some type of arthritis or else immune condition. And this is a subtype that can commonly affect the kidney, though it does have significant GI involvement as well. People who are on dialysis long-term can often get amyloid because there's one protein subtype that's not cleared with the dialysis and then can deposit. It's typically not seen until people are on dialysis for at least 7 years or more. And then there's a number of different genetic variations which have been seen. These are often referred to as TTR because the most common protein that's involved is tissue transthyretin, which is what TTR is short for. But it's important to know that that's not the only protein that's involved. And at present, there's been at least 30 different precursors which have been seen in people, and at least 10 different ones seen so far in animals. And this is from a number of different genes, and each gene has its own different profile. At present, there's been greater than 100 genes which have been seen. Then the next one to talk about, which I saw was the third most common here on the group, is what's referred to as age or else wild type. And this is where the protein deposited is felt to be TTR, similar to most variations in genes which are seen. But the difference is that the TTR is felt to be normal or else physiologic, and this appears to increase in a deposition with age. It's seen in about 15% of people past the age of 80, but for reasons that aren't clear, we can see it in people as well who are much younger. Then finally, on some occasion, we'll see people who have local production of amyloid within one specific area. And so from the standpoint of GI, we often will see people who have stomach involvement of amyloid without involvement in other areas. And that's typically a local production of plasma cells with light chain deposition in that area. It's much more rare than the other ones that I've talked about. Now, when we look at patterns of GI involvement with amyloid and why people get symptoms, the symptoms really vary based on where exactly the amyloid deposits. And from the gastrointestinal standpoint, the GI tract refers to everything from the mouth going down towards the anus. And so that goes through the mouth and throat, then the esophagus. The esophagus is the tube that connects the mouth with stomach. Then the stomach, where food is stored for a period of 4 to 6 hours and starts to break down. Then the small bowel, which is about 22 feet long, where we see most of the absorption of food. And then the large bowel or colon, which is about 9 feet long, which takes a lot of the fluid that makes it through the first 25 feet or so, and then condenses that to stool. So based on where amyloid deposits specifically in those areas and what layer of the gastrointestinal tract that deposits in, can help determine what symptoms that each patient will have. Typically within the gastrointestinal tract, there's a few different layers. And so when we think of people who have issues where we see amyloid deposition within the mucosa or else the inner lining, that tends to lead to problems with absorption. If there's more of a deposition within the muscle, then what we see in that area is problems with contraction and pushing things down. If there's problems with the nerves, and the nerves are interspersed throughout the muscle and mucosa, and then there's also layers of nerves which are on the outside of the tract, that'll affect the gut coordination and movement. And in fact, the gut has 500 million nerves which are associated with it. And then finally, if there's vascular involvement, that can affect both blood flow going towards the gut as well as how food and nutrients are brought from the gut out. So if we look at that inner layer with the mucosa, since that's where most of the absorption takes place, if people have deposition of amyloid in that area, then what we tend to see in terms of symptoms are diarrhea, and that's because since food can't get actually removed from the gut towards the blood, you keep the food in the gut, and that'll trigger diarrhea, and also malabsorption, weight loss, and bloating. And this is the area that if we're doing endoscopy and we're taking a biopsy, this is the only layer that we can get from our scopes. And so if we're doing an upper endoscopy or colonoscopy and biopsying, this is the site that we are looking at. If there's muscular involvement, then what we see are decreased contractions within the gut, and that can lead to more stasis and bloating and what's referred to as small intestinal bacterial growth, where there's higher amounts of gut bacteria because they aren't getting cleared and pushed out, and then that induces, at that point, diarrhea and malabsorption. There also can be this entity known as pseudo-obstruction, where sometimes there can be decreased motility leading to gut distension, and it almost looks like someone is blocked or else obstructed, but it's more of an issue of contraction and motility. And this is an area that we can't necessarily get biopsies from the muscle with doing an upper endoscopy or colonoscopy, but this is where imaging studies can help because we can look at the muscle layer thickness or doing specialized motility testing, which will look at the contractions. If there's nerve involvement, then typically the absorption and the muscle contractions are preserved, but the issue is the coordination of that. And so oftentimes, symptoms can cause diarrhea, constipation, but it's based upon coordination more so than decreased absorption or else strength of those contractions. And again, we can't get the nerve information from biopsies, but we can get that information from doing specialized motility testing or doing tests looking at movement throughout. And it's felt that the nerve involvement specifically may be an area that can cause prominent GI symptoms, particularly within the neuropathic variants of TTR. And then finally, vascular. And we have a number of blood vessels throughout the gastrointestinal tract, and if there's amyloid deposition along those vessels, that can lead to both problems with blood getting to the gut, which can cause pain and bleeding, as well as problems getting nutrients from the gut out. And that's something that we often can get to with endoscopy. Then we can see a few areas from the gastrointestinal system that are referred to as being GI, but are not in that direct line from the mouth toward venous. And that includes liver. The liver makes bile and helps filter toxins, and it it empties into the small bowel, but it's not in that direct line. We do see liver involvement commonly, and what we'll often see is with imaging, the liver looks bigger than what's normal. We can see bile duct involvement, though that's felt to be more rare, as well as pancreas involvement. And then occasionally we'll see involvement within what's referred to as the peritoneum, which is the lining that's outside the gut. Now, let's turn from here and talk about what symptoms patients experience. And if you think about the symptoms are going to be based upon the area of involvement and where exactly that deposition is. And so if people have involvement with the esophagus, then we tend to see two prominent symptoms. The first one is reflux, where things are going into the stomach and then coming back up in the esophagus. And then the second one is referred to as dysphagia, or else problem swallowing, where food is not getting pushed down well. In the stomach, we tend to see food sitting there more often than what's typical, which can lead to abdominal pain, to a sense of getting full more quickly than normal, to a sense of feeling nauseous, to occasionally throwing up, and also gut distension. In the small bowel is where most of the absorption takes place. And so if there's dysmotility or if there's any involvement within the small bowel, what we tend to see at that point is diarrhea, malabsorption, weight loss, and then what's referred to as pseudo-obstruction, where it can almost seem as if there's a blockage, but the issue is more gut bacteria and air. And then if there's involvement within the large bowel, we see both diarrhea as well as constipation, as well as fecal incontinence. Now, one challenge with this is that these symptoms can be relatively nonspecific. And if we look at how often these symptoms are seen, it's relatively common. And so in reflux, 20% of U.S. adults will have symptoms of heartburn at least once a week. So if someone presents with both reflux plus amyloid, it could be that the amyloid is worsening the reflux, but it may be that these are true, and unrelated. We do see about 4% of adults report problems with swallowing. A sense of what's referred to as functional dyspepsia, which is where there's a sense of getting full quickly, a sense of bloating, distension with meals. That's seen in up to 30% of people. We do see as well symptoms with irritable bowel in about 13% of people, constipation 15%, fecal incontinence in 6%. And if we look at that last one specifically, fecal incontinence is 6% of all comers, but it's 15% past the age of 60. And so oftentimes when we see people who have symptoms with amyloid, it can be very hard to separate, are these symptoms from amyloid or not, because these are just so commonly seen. Now, on top of that, just because someone has amyloid doesn't mean they can't have other conditions from the gastrointestinal system. And so we still can see inflammatory bowel, celiac, as well as certain types of cancers. Those aren't more commonly seen with amyloid, but they are seen also in the population. Then finally, when we look at some of these symptoms, many of them are commonly reported with medications. And so if you look at the average person who takes 5 or more meds, 4 of those 5 will have at least one symptom that's an adverse effect. And if you look at the adverse effects commonly reported with meds, typically GI tend to be at the top of the list. So it's often hard to separate when symptoms are present. Are those from the amyloid? Are those separate but common and not linked with it? Are these secondary to medication effects? Or is there something else going on that we have to take a look at? Now let's turn from here and talk about what tests we have and how they can be helpful. And the first test which I'm going to talk about is endoscopy and colonoscopy. And these are often the first tests which are employed. And what this allows us to do is to look inside the gut. We can look in the mouth, the esophagus, the stomach, and the upper section of the small bowel. And so with the upper endoscopy, it looks down about 7 feet. In terms of colonoscopy, typically we look throughout the whole colon, and then we'll typically look at the last foot or so of the small bowel. And so that looks at about 10 feet total. There's still a good 15 feet in the middle that we can't access with both of these procedures. But what this allows us to do is to look in, see if we see anything that stands out, if there's any strictures or narrowing, if there's ulcers, take biopsies looking to see if there's any signs of amyloid within the mucosa, and treat anything that we see that does require that. But the points to know are that because amyloid can deposit at different places throughout the gut, we're only going to see amyloid with the GI biopsies if there's actual mucosal involvement or if there's any vascular involvement. So if there's involvement of the nerves or muscle, then oftentimes that's deeper than what we can safely get from the biopsies that we take. Typically, if we're looking at the yield of doing biopsies in different areas, the highest yield is actually from the duodenum. Most series that have looked at if you take biopsies throughout the gut, at what point you're most likely to find actual signs of deposition. It looks like the small bowel is the highest. But we often will take biopsies from the rectum with the idea that the yield is still pretty good, and it's much easier to get to and much closer, and there's less involved in terms of doing that. Now, we do have a number of other tests which are available to help better define what's going on in the gut. And so if we look with upper endoscopy and colonoscopy and we don't find signs of amyloid, but we're suspicious that there is involvement that's potentially deeper, we do have a number of other tests that we could think about. And those fall into really three categories. We could pursue imaging studies, which can include CAT scans and MRIs and barium studies. And what those are looking at is to look at gut muscle thickness. And so if we're looking to see is there amyloid present within the wall of the gut, these can be tests that can give information to help guide that, as well as to look at gut diameter. If we will often look at motility studies, and these are studies that are more commonly performed at more tertiary sites, but they're studies that will look at the movement of food throughout the gut and to look at the strength of the coordination and what's happening with contractions. And so we can do this via radiology. One of the commonly done tests is where folks will take an egg that has a certain tracer in, eat the egg, and then we follow it with films looking to see how long it takes to go through. There's a test that's referred to as manometry, and this picture which you're seeing here is me getting this test back in 2006. And this is a test where there's a thin tube that has pressure sensors that can be placed anywhere throughout the gut and then looks at the contractions which are present. There's a test now that's referred to as wireless motility capsule, where you take a capsule and swallow it, and that capsule has sensors that will then look at the pressure throughout the gut. And then there's a test that's called a sit study, where you take a little a small capsule that has 24 little beads in, then swallow that, and then take x-rays looking to see how long that takes. But all of these studies can, in different ways, look at the strength of contractions and the speed with which things move through. Then finally, we have breath tests available. And breath tests are tests that look at the gas production and try and assess what's going on at that point with absorption and with gut bacteria levels. And these tests can all be helpful to better define why people have symptoms and then try and tailor the therapy based on that. Now, what treatment options do we have at present? And the key point is that, treatment should really be tailored to symptoms plus the area of GI involvement. And I'll say that we often will start with treatment first before we do a lot of testing. And if I'm seeing someone who has a known history of amyloid and they have GI symptoms, I do think it's very, very reasonable to start first with treatment with commonly performed therapies that are thought to be safe, to try and get things better with symptoms. And then if things are not improving as we expect they are, that's when we at that point step back and do testing. So in terms of the treatment really varies again based on the area that's involved, plus symptoms which are at play. And so if we look at the esophagus, there's two main symptoms that we see with that. The first is reflux, the second is swallowing. And so if reflux is what's most common, then our first step is often diet and lifestyle. And what we try and focus on specifically are to first look at weight loss if that's a factor, because abdominal pressure can force things back up. And so there is a thought that if your weight is too high, that dropping about 5 pounds can help in that setting. If there's nighttime symptoms or symptoms first thing in the morning, then we'll often try to separate meals from lying down by at least 3 hours, and then we'll try and raise the head to the bed at night. And it doesn't have, it's a balance where if it's raised too high, then you slide down, you can't sleep. If it's too low, it's probably not doing much. And so we say to aim for probably about somewhere between 2 and 4 inches. Now, there's a number of different diets that are proposed, and not a lot of evidence to back them up. There's one paper that looked at doing more of a vegetarian diet that seemed helpful. What we typically recommend are doing small, low-fat meals to try and minimize stomach distension. And if there is any clear food trigger that's involved, to try and cut that out. But there's not good evidence that if you cut out every food that's potentially associated with GERD, like tomatoes and chocolate and caffeine and peppermint, et cetera, that necessarily makes a difference unless you have symptoms associated with those foods. In terms of medical therapy, the mainstay are typically therapies that are geared towards decreasing acid production. And so we have 3 meds in this category. There's antacids such as Tums, which work relatively quickly, are very safe, but are not tremendously effective. The next step up are referred to as histamine receptor blockers, which are things like Pepcid and Zantac. These are meds that are much more effective and work for about 6 hours. But if you do take these around the clock, they don't work as well because they have resistance associated with them, but they are quite safe. Then the third option are referred to as proton pump inhibitors, and these are things such as Nexium, Protonix, that category. These are by far the most effective meds we have at blocking acid. There's not felt to be any long-term resistance with them, but they are much more expensive, and there are some worries with them with regards to absorption and potentially increased infection. That being said, we think of these drugs still as being relatively safe, and these are very commonly used drugs, not just with amyloid, but throughout the U.S. Right now, if you look at the 5 top-selling brand name drugs in the U.S., 2 of the 5 are actually in this category. Then if we get beyond just blocking the acid, we do have some other medical therapies that we can employ to try and speed up the esophageal emptying or try and buffer the sphincter pressure in the lower esophagus. But these particular therapies tend to have more risk associated with them, and we don't often employ them except within select cases. There is a role also for doing mechanical therapies to try and make the sphincter more tight. That really has to be done on a case-by-case basis because there is risk with that as well. If there's problems swallowing, then once again, dietary modification is often the first-line step. And so if people have problems with solid foods but do find it with liquid, well, we'll try and at that point to try and make food softer, to lubricate it, to do more soups and things along those lines. If there is any narrowing, we can go in with endoscopy and take a balloon and try and stretch and make things, a little bit more wide. And then some people with amyloid will get more of a spasm that's present within the esophagus, and so in that situation, doing a Botox injection can help in that scenario. If symptoms are from the stomach, again, the first step is often dietary modification. And what we're trying to do there are to do a diet that will lead to less gut distension as well as faster stomach emptying. And so oftentimes that'll be small, low-fat meals. Fat seems to make gastric emptying slower, and so oftentimes the less fat that's present, the faster stomach emptying. Typically, solid is much slower to empty than liquid, and so more smoothies and shakes and things along those lines may help. We'll try and switch the large meal if possible from dinner toward lunch, and then also separate the time once again from dinner to lying down. We have a number of medications that can speed stomach emptying, and so I've got those listed here. The only one that's FDA approved to speed stomach emptying per se right now is Reglan, but Reglan has a number of adverse effects with it, which make it a less attractive drug for long-term use. So in practice, we'll often use the ones which are listed below it. Typically, erythromycin and azithromycin are both antibiotics, but speed stomach emptying as more of a side effect of that. Domperidone is not FDA approved, but you can obtain it with an application from the FDA, and so a lot of more specialty sites will have access to use that via the FDA's research site is legal. So while it's not FDA approved, it is something that can be prescribed here in the States, and that may increase stomach emptying without quite as much of the adverse effects of Reglan. Then recently, prucalopride was FDA approved in 2018 for constipation, but this has been used in Europe to treat stomach emptying issues since 2014, and there was just a recent paper that came out last year that showed it did work for that here as well. So we have used that if there's both stomach emptying issues plus constipation, and safety appears excellent with that. There are also a few categories of medications and herbs which are designed to let the stomach expand more. And so the one prescription one that falls in that group is Buspar, which is actually an antidepressant, but it works through serotonin type 1, which is largely expressed within the upper stomach, and it lets the stomach expand and hold more. There are as well category medications that will make the gut less sensitive, so that it won't necessarily increase the emptying, but it will make people less symptomatic with the food that's there. We'll sometimes look at medications that will just treat the nausea specifically, and those are things such as Zofran and Phenergan. And then once again, we do have some options with endoscopy. And so if people have any strictures or spasm, we can try and stretch or else inject in that area. In terms of the small bowel, the main symptoms, again, in this are malabsorption and diarrhea. And so we do find if we modify the diet to induce less foods that are potentially malabsorbed, that can help with symptoms. And so oftentimes we'll cut out sugar and processed foods, and that does appear to help, in particular with both bloating and diarrhea. Prokinetics, which are meds that increase the speed with which the small bowel moves, do help in this scenario. And it's a little bit counterintuitive because you think, well, if things aren't getting absorbed and there's diarrhea, why would I want to speed movement throughout the gut? But the reason is that if you increase contractions, you actually clear bacteria from the gut better, and then there's better absorption based on that. So somewhat paradoxically, speeding the gut does help in terms of that. If there's thought to be small intestinal bacterial overgrowth, which we commonly see with this, then doing antibiotics can help. Octreotide is a med that is injectable, so it's a little bit of a hassle to do, but it increases small intestinal movement, plus it decreases secretions within the small bowel. It can help with this. About 20% of people with diarrhea will also respond to meds that bind bile, and so sometimes we'll try that. And then finally, we do have medications that can just help in terms of slowing movement throughout the colon to try and make make things better with diarrhea. And those are things such as Imodium, which are, reasonably safe and common. And then the most aggressive one we have is tincture of opium. And tincture of opium is a liquid distillation that you can think of as being all the GI adverse effects of opiates linked into kind of one liquid package. And so it gets a profound slowing of the gut without necessarily the more classic symptoms with opiates. And this is something we don't use often because it's often difficult to get covered with insurance, but I've had some people do, really remarkably well with it. In very rare cases, we'll also look at doing supplemental nutrition with the IV, but I'll say from personal experience, this is exceedingly rare. And then finally, in the colon, we tend to see constipation often with this because the colon will, in health, it moves what's left from the small bowel towards the rectum in about 36 hours and makes it more thick. And if the colon is not contracting, then you can get larger amounts of stool that sit there and don't clear. And so in that category, we'll often look at dietary approaches. Somewhat paradoxically, fiber can be both good and bad based on the person. And so some people who really don't push things through from the gut, increasing the fiber in their diet may just lead to more bulk without improvement. Some people, the increase in fiber then triggers contractions and then can help. So that's really a case-by-case basis. We will look at dietary modification as well, and some things such as prunes, for instance, can be a natural laxative to help get things going. And then in terms of laxatives, we have both medications available in the drugstore. The ones that we use in that category most often right now are Miralaxena, as well as compounds that contain magnesium. And then we now have 4 prescription drugs as well. And that includes the ones which I've listed here. I say of these 4, precalipride, which is the 4th one, we often like because it also increases motility in the stomach and small bowel as well. And so that's often a nice fit. So let me turn here and talk about what we know about the yield of doing endoscopy with the gastrointestinal tract, as well as specific variants. And it's interesting to me that the main studies that have looked at how often we see GI involvement with amyloid have reported numbers that have struck me as being relatively low. Now, I'll say that I'm biased in that the people that I see in my clinic are referred to me specifically because of symptoms. So in my practice, it seems quite high. But I'm sure there's a very large group that never makes it to my door. And of the 3 biggest studies that have looked at this question, the first one in 2013 looked at over 2,000 patients, most of whom had AL, and reported that only 3% of them actually had biopsy confirmation of amyloid from the GI tract. Now, to be fair, not all of those were sent towards endoscopy and colonoscopy, and those that were sent, not all of them got biopsies from every area. So that's probably an underrepresentation, but still 3% is awfully low. In 2015, within a Korean study, they had 24 patients within 155, so 15% in their series. And then at Stanford in 2017, they reported gastrointestinal symptoms in about 16%, and then of those patients that went towards biopsy, they only had 45% confirmation with amyloid of that 16%. So all 3 of these paint a relatively similar picture that GI involvement in the mucosa does appear to be low, or at least lower than I would think it would be. Now, that doesn't mean that, overall GI involvement is low, because not everyone went towards procedures. And once again, the biopsies are only going to pick up the very inner layers. Now, what do we know about the different variants? And There's not a lot of literature with this, but it does look like that if you look at the paper from Theos in 2014, that GI manifestations are common within the neuropathic variants. And so they had done a survey of close to 1,600 patients, most of whom had a variant, most commonly B3rd-M, but they did include 160 that were wild type. And what they found was that with the group that was hereditary, that the bulk of them did have gastrointestinal symptoms, but in wild type it was only 15%. And they found that most common symptoms were weight loss, a sense of getting full quickly, and then constipation and diarrhea. And they felt that when they looked at the variant specifically, that the B3rd-M type appeared to have a higher rate than some of the other ones. And this appeared to be most common in those under the age of 50. Now, they went on to conclude that for patients with predominantly cardiac complications and wild type, that they felt that the prevalence of gastrointestinal manifestations was not higher than that expected within the general population. If you look at symptoms with time, it did appear that as people had deposition for a longer period of time, they did have more symptoms within this 10-year follow-up. And if you looked at the subtypes specifically, bottom line was that variants that were felt to be more linked with a neuropathic site, so more nerve involvement with the variants, tended to have increased GI symptoms. And of the group that had primarily a neuropathic variant, greater than 60% of them would have prominent GI symptoms that were felt to be more so than what was viewed based on just age and chance. But of the group that had mostly cardiac and wild type, there was GI, there were symptoms in about 15%, but keep in mind that that's similar to what we see in the general group. So now let's talk about new treatment options, and this will be primarily with the TTR based. And we've really seen a real revolution within the landscape within the past 3 years. And we've gone from really no good options besides NSAIDs and liver transplant to now 3 drugs which are FDA approved within the last 2 years. And so there's been a number of features that I think are making, are increasing the diagnosis and the awareness of this. One is that we now have treatments and they appear to work quite well. Second is that we now have increased genetic testing, and so a lot of the at-home kits, like 23andMe, for instance, will now look at the common variants associated with this. And so there are people who are being told based on these kits that they have susceptibility towards amyloid, who are then looking in and getting additional testing. And as we've had better testing, we've now identified increased mutations that previously weren't known to cause this. And so that's all led to a marked increase in both awareness as well as diagnosis. Right now, from the TTR category, we have 2 primary families of meds. The first group reduces synthesis of TTR. The second will try and stabilize what's there. And so we now have options for both hereditary as well as wild type, whereas prior to 2018, we really didn't outside of clinical trials. Now, there's not good literature at present to show for people who are treated with these meds and who benefit from other amyloid-type symptoms, what happens with their GI symptoms. But I can say from personal experience, I've now seen several patients who have been treated with these meds who have come in and have told me that they're doing better from a gastrointestinal standpoint. So my belief is that with long-term effective clearance and therapy, that there can be improvement from from a gastrointestinal standpoint, but this is based on personal experience and small numbers, not based on papers at this point. And then finally, when to see when to see a GI doctor. And this is the general rule I'd follow. I think if there are significant symptoms that are not responding to diet and not responding to supplements that can be obtained without a prescription, then that's a good time to step back and see a specialist. If there's questions with regards to weight loss or else possible nutrition issues, if there's anything unusual in the presentation, so there's things like bleeding or anything that suggests something outside the norm, or if there's a need to do diagnostic testing. And so in my practice, and I think the way that I'd recommend is that if people present with symptoms, then I think it's very reasonable to treat those first before embarking upon doing diagnostic testing. But I think if there are symptoms that are present that are not responding towards therapy, then that's a good time to step back and do testing at that point. And what testing allows us to do is to look and see, is there deposition of amyloid? Is there something else that's common that could cause the same symptoms and mimic it? Because, again, a lot of these symptoms are nonspecific. And do we see any potential complications, such as ulcers or other things along those lines that we'd treat differently? So on that note, I'll just conclude by saying amyloid can cause symptoms through direct deposition or via involvement of the nerves, that only mucosa can be evaluated with endoscopy. And so if we see deposition with the biopsies, that's very specific. But if we don't see any with the biopsies, that doesn't exclude the fact that there might be amyloid in other areas. We do see involvement commonly within familial, particularly neuropathic variants, but it's unclear if with cardiac predominant and wild type, if what's being seen is higher than the general population. Diagnostic options and treatment options exist and can be customized based upon specific symptoms. And new options for treatment are leading to increased awareness and potentially long-term improvement in GI symptoms, though that needs more information at this point. Thank you very, very much. I'll happily take any questions.
All right. Thank you, Dr. Clarke. That was excellent. We do have quite a few questions. And I think the best way to do that is to just push them to the slide area so that all the viewers can see the question. And then if you want to go ahead and vocalize your answer, we can do that. Okay, so I'll try to go in order here. And we'll try to get to as many as we can. The first question here is there anything that can be done to stop explosive vomiting in the morning besides not eating after 5 p.m. the night before?
Yeah, so great question. And, when we see vomiting in the morning, it can be from really one of two things. One might be that things aren't emptying well from the stomach and there's more retention in that area. The second might be reflux. And oftentimes vomiting, it can be tough to separate that. So in terms of dietary approaches, what we'll often say is again, separating the time between dinner and lying down, just like it's being done there. If you've got the flexibility to do so, maybe making lunch the bigger meal and dinner smaller is helpful, or doing liquid dinners like soups and such. Typically, liquid will empty the stomach in about 40 minutes, and solid food is typically about 6 hours. So doing liquid more may help there. In terms of medical therapy, the two approaches that we would often do in that scenario are doing something to treat the acid in case it is a reflux association, and something to try and speed stomach emptying. And this would be a scenario where I think doing something like erythromycin, like one of those prior prokinetics, which I talked about. Doing that perhaps right before dinner, right before sleep might help in that scenario. Two that we often would do that are reasonably safe are bothanicol and second one is protistigmine. The trade name of that is Nestanon. And those are ones which are reasonably short acting, but what that'll do is help the stomach empty a little bit. So if you did that right before dinner, right before sleep, and then increase the acid meds, I think that would help hopefully in terms of that.
Great, thank you. So this next question here is about any drugs that might be rough on the GI tract that you're aware of. I'll go ahead and share that. Okay.
Yeah, I'll say that it's hard with meds with the GI tract in that a lot of meds can cause gastrointestinal effects, and I'll say I'm not familiar with the specific GI effects with those meds particularly, but the ones that we often say to try and stay away from are what's referred to as NSAIDs like Advil and things on those lines that can cause a lot of GI pain plus can also potentially affect absorption as well. We'll often stay away from opiates. But I can't answer those three specifically. My gut feeling is that doing it sub-Q or IV probably wouldn't make a big difference because a lot of the gastrointestinal effects with it are more based upon the change within endorphins and other chemicals which are released more so than direct contact. So I don't know if their route for those per se will make a difference.
Okay, great, thank you. And this question is about how long it might take for the GI tract to repair itself following a stem cell transplant, or I guess if you could speak to any type of treatment in general for that question.
Yeah, so great question. You know, the gastrointestinal tract can take a while to fully recover, and when we look at things such as ulcers, we often say that that's about 12 weeks until it's better. There's this entity known as post-inflammatory dysmotility, where people get very marked GI inflammatory or else infectious process, and the gut essentially becomes neuropathic and then gradually recovers, and that length of time is as long as 24 months. So I think for stem cell transplant, that's a pretty rigorous step, and there's a lot of GI microbiome shifts and such which are there. So I think it's probably going to be at least 12 weeks, but in most people probably in that 6 to 24 months.
Okay, great. And there are quite a few questions about probiotics. So could you speak a little bit about that?
Great. Yep. And to back up, I guess, a little bit with the last question. I mean, to kind of paint more of an optimist, to be a little more optimistic about that 6 towards 24 months. I'm saying until things are back towards baseline. I think that there is a gradual improvement throughout that process. So going towards other probiotics per se. So this is a fascinating question, and to give a bit of background, the average person has about 3 pounds of gut bacteria which are present, and we don't have a good idea at this point as to what's normal. What we can culture and test is either from the very end or else start. And we think that there's segmental differences within gut bacteria throughout. We also can only culture about 20% of what's there. So, and it's felt that every person has a microbiome profile that would be distinct enough that it's as different as let's say a fingerprint. So benefit of probiotics are that the thought is that you're giving back live bacteria to try and repopulate the gut with bacteria that's thought to be better in health. There is good evidence that probiotics can help with certain symptoms such as bloating. And there is good evidence that if you do a course of probiotics and you check metabolites within the stool, that the probiotics that you take do affect the gut gut bacteria diversity, and so it's a very interesting area. The challenges with it are that the probiotics are not regulated by the FDA at present. So there's a relatively loose threshold to say what type of bacteria it is. There was one study where they took a number of different types of probiotics and tried to culture what they said was in, and they could in less than 50% of the cases. There's as well a publication bias where studies that show that they help are more likely to be in journal. Studies that show it doesn't make a difference are more likely to get rejected. So it's a little bit controversial, but I think what we can say is that the probiotics do help modify the gut flora. They do help in particular with bloating. Safety seems reasonably good, and so I think my practice is that if people are interested in trying it and want to, I think it's worth a shot. If people do try, it does appear to take at least 28 days before the probiotics which are taken modified the gut bacteria metabolites. So typically we say that if you are doing a trial, try it for 6 weeks, see if that works. And if you haven't seen any difference after 6 weeks, then stop. Not the same one may not work for each person. A lot of these different types of probiotics are based on normal populations that may not really translate towards every group. And so, if one group of bacteria is commonly seen in people who are from Sweden in their 20s, that may not be the best type for you, but that might be what's in theirs. And if you are going to use a probiotic, the two that appear to have the best literature are probably Align, which is ALIGN, and as well as VSL number 3. And so I think one approach is trying one of those based on papers which have been published. The other is to just try and take more food which is processed, such as kimchi and sauerkraut and things along those lines. And there's no good studies showing one approach is better than the other in that context.
Okay, great. Thank you for that. And then the next question here is, what are your recommendations for dealing with weight loss and with that loss of strength as well? Yeah.
So I guess with that, that question could be interpreted in two ways. If it's weight loss from amyloid and the goal is to try and gain weight back, then what we often will do in that scenario is to work closely with our colleagues from nutrition. We'll often look at doing supplements and shakes, which are more dense within calories, but may have faster emptying. And we'll sometimes look at doing antibiotics to try and lessen small intestinal bacteria to try and increase the absorption. In terms of loss of strength, that's often associated with both the weight loss nutrition issue, and then also I think if there's a neuropathy or cardiac issues, that also factors in. So I think as much as possible, what exercise that can be done can help in terms of keeping the muscle in that area. Now, if the question is how to lose weight to improve the gastrointestinal symptoms, that's a different answer. But I think this was probably meant as how to gain weight in this scenario.
Yes, I would agree. I think that is what they were getting at as well. Okay, so then we have a question here about G-tube and formulas. Can you recommend a good formula for G-tube feeding?
Yeah, I think for that, it's kind of like food, where each person is a little bit different in terms of what they best tolerate. I'll say that we often will, in terms of formulas, we'll start with things like Ensure. We tend to use Kate Farm a bit here, which is more of it's a formula that's more natural and organic, and we've had some success with that. Sometimes when there's a question of potential malabsorption with the tube feeds, we'll look at doing a tube feed that's more elemental, meaning that that's already broken down to some extent, and so there's less work that's required to absorb it. And in that category, Peptamen is often the one which we do. It's Peptamen. So I think if there's diarrhea, with the tube feeds, the ones that I would think about trying would be Kate Farm or else Peptamen. And in terms of the diarrhea, if you're having diarrhea despite those meds at present, the two things that I would think of would be to potentially do a course of antibiotics and see if that decreases small intestinal bacteria and may help there. Or we've had some we've had some successes as well with tincture of opium.
Okay, perfect. Thank you. The next question is interesting. This is on intermittent fasting. Is that a strategy that has ever been looked into that might be helpful in dealing with these issues?
So that's a great question. Yeah, the short answer is we don't have evidence at present, but this is a really, really, really hot topic. And right now at Stanford, we have trials looking at intermittent fasting for therapy for both inflammatory bowel as well as reflux. The background for those who might not be familiar with it is that the concept is to have a longer period of fasting to try and go into a state that you're breaking down fat more actively, and this can be as simple as just skipping breakfast and doing lunch and dinner within a set time period of 6 to 8 hours, or it can be as being as aggressive as doing fasts of 24 to 72 hours. But in terms of GI symptoms with amyloid, no research specifically looking at that. But if you look at other GI symptoms, it's at least been hypothesized to potentially help with bloating and reflux, though there's very little information at present on that.
Okay, thank you. And we actually got a question through our email. Is there ever gallbladder involvement that you're aware of?
There can be, and it's thought to be much more rare than the other areas that I've talked about. Now, part of that may be that when we're doing biopsies, we're biopsying from inside the GI tract. We're not biopsying, that area per se. But it is reported, but it's exceedingly less common. Now, I mean, to make it tough too, is that we do see symptoms with gallstones and what's called a biliary dyskinesia, which is where it doesn't squeeze as well, pretty frequently. So I think if those symptoms are present, it would be very hard to then separate is that amyloid or not, just because those symptoms are so common. The only way to probably know if it's from the amyloid would probably be to at that point take it out and stain it. But it is reported, but it's thought to be uncommon.
Okay, great, thank you. Let's see here. So there are a couple questions on a low FODMAP diet. Can you first explain to the audience what that is, and then also speak to whether that may or may not help?
Yeah, so that type of diet is one where the concept with it is that it's really a diet that was was made for symptoms with irritable bowel, but the concept is that you minimize foods which are gas producing, and most of the foods that are gas producing are also foods that are potentially malabsorbed as well. And so you try and minimize those foods to see if doing a very low gas production diet will help with symptoms. And the foods that are cut out are in 5 different categories, but they're things such as fructose-containing things such as apples and pears, types of green vegetables which are gassy, and essentially you cut out those categories at first, and you're on a reasonably restricted diet. And then if you feel clinical improvement with it, then you gradually will re-add the foods back in. Most people who are sensitive to foods in the FODMAP category aren't sensitive to all foods in it, so it's a way to really eliminate everything and then slowly build things back up. There is a thought that this diet can be very helpful in small intestinal bacterial overgrowth because a lot of the foods that make gas because the bacteria process them. And so if you have a diet that's low in these foods, which are potentially small bowel accessible to be processed, then in theory that would decrease the growth of certain types of bacteria in the small bowel. And so when we treat small intestinal bacterial overgrowth, we'll often include this diet as part of the therapy. For the low FODMAP diet specifically, I don't think it would make a difference with the stomach or else the esophageal issues. But I think, if people are bloated, distended, or have issues with diarrhea or malabsorption, this is a reasonable attempt.
Okay, interesting. Thank you. There are a couple of questions between amyloidosis, GI involvement, and liver issues or pancreas issues. Can you speak to any trends that you've seen with those?
Yeah. So I guess first, liver is felt to be commonly involved. Which makes sense mechanistically. The liver is the main site that toxins from the blood are filtered and cleared, and so if these chains are going outside the blood, oftentimes liver is one of the areas that these will go to. What we tend to see is that there's liver enlargement with imaging, and if we do blood tests, there's one specific blood test, the alkaline phosphatase, that often is increased. Thankfully, the liver, from just enlargement, often doesn't have tons of symptoms. The liver has no pain sensation within it, but there's a capsule that's outside the liver, and so as that gets stretched, that can cause pain primarily in the right upper section of the abdomen. If there's marked involvement in deposition, then that can affect the function of the liver, and then it might not clear things as well. That's thought to be less common, but it is something which we do occasionally see. Most of the TR is made in the liver, and so liver transplant has been one of the therapies that's been used to treat this with variable success. From the pancreas, there is pancreas involvement, but it's a lot like the gallbladder, where it's probably underreported, but it's thought to be less common. Typically, the pancreas does not have as much deposition in those areas. But to be fair, it's not an area that we often biopsy. So it might be there and we aren't seeing it, but it's felt to be less common than the other areas.
All right, thank you. When would you recommend that patients take meds? Before a meal, after a meal, or during?
It's going to vary based on which meds specifically are being taken. For most of the ones that work upon the gastrointestinal tract, we generally will try and do those prior to meals. And so with medications like a Nexium, Protonix, things along those lines, we'll often say first thing in the morning. And then if there is a second dose, typically about 30 minutes before dinner. For meds such as Pepcid and Zantac and things along those lines, those last for probably be between about 4 to 6 hours. So oftentimes we'll say to do that when symptoms develop, or doing it about 15 minutes prior to meals. And then things like Tums and things along those lines can be taken whenever. For meds that will speed stomach emptying, we'll often say to take those 15 to 30 minutes before meals, but we'll often do a dose at bedtime as well, with the thought that may help with some of the nighttime issues. With antibiotics, not good evidence that makes much of a difference with timing. But we'll sometimes say to take it with meals if people get a potential stomach upset with it in terms of taking it. And then there's one type which I talked about, octreotide, which we'll often do subcutaneous at night just before sleep.
Okay, great. Thank you. So I think we have time for about 1 or 2 more questions. And I know we have a lot more than that are in our inbox. So we will try to follow up with you via email afterwards and try to get everything answered. But just for the final few questions, let's see, we have, what do you recommend for issues with bloating?
Yeah, so that typically when we see that, the main things that we look at are increased small intestinal bacteria, possible dysmotility, possible malabsorption, and if we look at where to go after that, we'll often try a low FODMAP diet and see if that helps. If it's an issue of dietary malabsorption there, we'll often do courses of antibiotics looking at small intestinal bacteria, and we'll often look at meds which will increase motility in the gut and see if that'll pass the air out more. So I'd say some combination of those 3.
Okay, great. Thank you. Okay, and I know you did mention in your presentation long-term effects of some of the over-the-counter and prescription medications, but this question is about Reglan specifically, and can you speak a little bit to long-term?
Yeah, so this right now is the only drug that's FDA approved specifically for stomach emptying, but it can be associated with a risk of what's referred to as tardive dyskinesia, which is a irreversible movement disorder, and it's often it's like a mouth smacking movements, things along those lines. It's reasonably rare, so that that's in less than 0.1% of those that take it long term, but it can be devastating when present. Now, for those that take reg in short term, up to 40% can have some adverse effects. The most common are typically anxiety, and just a sense of being wired and kind of awake. And then about 10% will get a temporary tremor that is there when they take the med and disappears as soon as it stops. Now, that being said, for this question specifically, if someone has been on it 30 years and has had no symptoms whatsoever with it, then I'm less worried about them getting this issue. There is a thought that the one worry that we have with the tremor that doesn't disappear is based upon long-term use. But if it's been 30 years and that hasn't developed yet, then for reasons that are probably not clear, this person, is probably unlikely to get that going going ahead if it's been 30 years and haven't yet.
Okay, great, thank you. So I think that is just about the end of our time. I'm going to put up the last slide here. All of the questions that were not able to be answered are saved, but if anyone has anything that did not ask yet, please email us and we'll do our best to get you some answers. And there are a few slides that Dr. Clarke put together on different modifications and over-the-counter and prescription medications, and I put those together in a handout, and those should be in your resources tab in the bottom right corner of this platform. But if you'd like that emailed to you, you can send a request to us at arc@arche.org. And yeah, thank you all for tuning in, and thank you so much, Dr. Clarke. This was very informative.
Oh, thank you. Thank you. It's a pleasure.
Great. Thank you so much. Everyone have a great day.
Thank you. Thank you. Thank you. Appreciate it.